Warm greetings, everyone. Welcome to today's Physio TV session. I am Dr. Soumya Gandhi from Sancheti Institute College of Physiotherapy and the moderator for today's session. We also have our panelists, Dr. Sona Kolke ma'am, Associate Professor and Head of the Department of Kinesiotherapy. Our topic for today's Physio TV discussion is role of cognitive behavioral therapy in management of pain and neurological conditions. And it gives me immense pleasure to welcome our speaker for today's topic, Dr. Hamza Godhrawala. Sir has an MSc in Advanced Physiotherapeutic Practice, MSc Physician Associate, postgraduate diploma in Cognitive Behavioral Therapy, and postgraduate certification in Sensory Integration. And over 15 years of experience working with clients with complex neurological health problems across England and Scotland. He specializes in cases including management of acute acquired brain injury, birth injury and developmental delay, brachial plexus injury, cerebral palsy, spinal cord injuries, major trauma, chronic pain, orthopedic and neurodegenerative disorders. He is a member of the Chartered Society of Physiotherapy, Health and Care Professions Council, Association of Chartered Physiotherapists Interested in Neurology, Case Management Society, United Kingdom, and Medical Legal Association of Chartered Physiotherapists. Sir, we welcome you for today's talk, and I will now hand over the session to you.
Good morning, everyone. Thank you for the lovely introduction, Soumya. And thank you, Sonal ma'am, for giving me this opportunity to speak on this topic. Cognitive behavioral therapy. So going by the name sounds more of a psychological domain, but as a physiotherapist, I take it's a vital tool to have in your armor, especially addressing pain, both at the acute stages and more importantly, chronic stages, where almost all possible avenues of treatment modalities, pharmacological options, and perhaps even managing it at a high level, psychologically impacted consequence has been exhausted. So we want to make sure we've got something else to offer to these clients, because at the end of the day, they are looking for answers as to why is pain still a major contributing and limiting factor to their quality of life and their functional activities of daily living. So CBT is quite broad based, and to try and cover it up in one session is extremely difficult. Having said that, I think what we will do today is try and introduce the topic in a subtle way, come up with some key areas where we can focus, where CBT can be used, and try and come up with a little plan as to what exactly will CBT offer in terms of initial assessments, picking up the right type of patients for that, and then how do you actually proceed with the therapy sessions. Being a physiotherapist myself, I think the key element we will focus is how can we implement this in our practice as physios, as opposed to that being dealt as a predominantly area by the psychologists or the psychiatrists. Of course, they are experts in their particular area, but not everyone can have access to a psychologist or a psychiatrist, especially from a pain perspective. And as physios, be it any specialty, musculoskeletal, cardiothoracics, sports, and for that matter, even neurosciences, the element of pain is always going to be an important factor. So I'm going to be stressing more on how we as physios can implement that in our session today, hopefully. So trying to simplify what cognitive behavior therapy is all about. So if you try and break it down, the first two words, it basically says cognition and behavior. So the entire focus of CBT is basically based on one's cognition. And then depending on their cognitive levels or their cognitive perception, what is their behavior towards that particular problem, task, or at a very simple level, what is their behavior towards that particular thought? So the word thought will keep revolving in the session because it's all based about what you think and what thoughts are revolving around you that gives you this perception of maybe pain or any other feeling which you now feel is beyond your limits to resolve it. Having said that, when I say beyond your remit, you've already been in touch with various specialities, and you now find no other alternative to try and tackle this. So basically, cognition, your perception towards a particular thought, and then the behavior towards that particular perception and thought. So it will keep revolving around these three factors: cognitive ability, the behavioral process, and then eventually we're looking at what is the action towards it. Now, as physios, very important for us to realize that, and I'm sure everyone is aware of the fact that action and cognition, they go hand in hand. So more from a neurological perspective as well, I come back to the traditional norms of motor relearning, which although they say it is more specifically related to neurological population, but as a matter of fact, for any particular rehab, be it any specialty, MSK, cardiothoracic, sports, and neuro, of course, the concept of motor running will keep revolving around. You keep practicing a particular task, you keep practicing a particular mental task, and eventually you expect that will become a habit as a process, and you see those results. So similar concept for cognitive behavior therapy. What you want to try and find out is what is this particular cognition that leads to this particular action. So there could be a problem lying at the cognitive level, okay, or there could be a problem lying at the action level. Now, both of them are linked together in a very strong pattern. And if we go slightly in detail of the anatomy of the brain, the deeper cerebral cortex, you got our interconnected pathways, and very closely related are what we call our somatosensory homunculus features. So you have your motor control strips, and then very adjacent you have your sensory strips. So between the two, there is always these elements of cognition highlighting in all the four lobes of the brain. They've got specific functions, the frontal lobe coordination, temporal lobe memory, parietal lobe, what we call association patterns, and the occipital lobe with the visual pathway. So there is this very important factor for us to understand that if cognition is affected, action will be affected. Vice versa, for whatever reason, if there is just the problem at the action level, as in, say, for example, MSK injuries, there is this local problem of, for example, a fracture not healing or chronic low back pain. So we are specifically addressing just at that particular muscle or bone or movement pattern level, which is action predominantly. But eventually, that particular action will have impact on the spinal cord level, which will start affecting your cognition, because you're constantly thinking about it that, because of pain, I cannot do X, Y, Z. Or the other way around, you already have a thought process in your mind that I cannot do this because of X, Y, Z. So very important for us to understand the fact that we need to address both action and cognition at the same time. Otherwise, one will superimpose the other, and we will be left in a limbo. Not good for the patient, of course, but more importantly, as therapists, we will get frustrated thinking that, I'm doing every possible thing for this patient in terms of the right exercise program which has been prescribed. Nevertheless, to talk about motivation levels and patient active involvement is a completely different story. But at least we want to make sure our bases are covered, that I'm not only just dealing with the action part by giving them an exercise program or a particular, for example, manual therapy for MSK clients and stuff. But hold on, is this person's cognitive level at that optimum that it takes in that input to then give us effective results. So again, the word action and cognition, very important from a CBT perspective as well. Now, I've not made any presentation. This is part of my normal talks that I give to students and other batches. So what I will do is I will try and summarize brief parts as we move on. So let's try and understand CBT concept initially in slightly more detail. I'm just looking at the watch as well to make sure I've got time constraints to not overdo, because this is a topic which can go on and on and on, and we won't end up with the actual remit of this. So basically CBT revolves around what we call emotions. Now, having addressed the fact that a particular activity or a particular injury will lead to a particular emotion. Now, it is very difficult to change someone's emotion. You once you feel something, that's it. That's registered in your limbic system, and you have a perception towards it that this is how I feel. Now, this varies across the patient spectrum, depending on, number one, the level of injury, of course, at a basic level. The more severe the injury, the more severe the emotion, obviously. Secondly, previous concepts or previous perceptions to that particular injury as well. So if it is something which is a repeated pattern of injury, now when I say this, I do not mean repeated trauma. Yes, that could be one of the things. But say, for example, clinical cases of fibromyalgia. So, there is this established diagnosis in which pain plays a very important role for them. It is one of the major limiting and contributing factors. Similarly, moving to the neuro domain, multiple sclerosis. So for them, fatigue is a major limiting factor, but then fatigue induces pain. So with any particular clinical condition, or if you're looking purely from a psychological perspective, each individual has a particular thought process, and depending on their level of cognition. When I say level of cognition, I also mean the level of education as well, as to what is their understanding in terms of within the limitations. So they will have a particular emotion towards a problem. So in summary, one point for CBT, there is an emotion associated to a particular task, activity, event, or particular clinical condition. Now, our job as CBT therapists is to try and find out as to what is the impact of this particular emotion on the person. Now, it sounds it's a very, very fancy statement, and looks nice when you're talking about it. But how do you actually do it? It is quite not only challenging and daunting, but more importantly, you have to understand the patient's perception towards it, and it's not a one-fit solution for all. So everyone has a different perception towards a particular problem. So to try and find out what you think about this and what another person thinks about it is a difficult task. Nevertheless, the background and what you need to keep in mind is there's a particular emotion linked to it. Now let's find out in detail as to what this emotion is playing around with this person. So that eventually simplifies things from a cognitive behavior perspective. Now, once we've identified a particular patient, which we will talk in detail in a minute, as to not every patient will be suitable for cognitive behavior therapy. Similar like any other clinical specialty, not everyone is suitable for a particular surgery or a particular mode of treatment. So you eventually channelize and then simplify your process and then select that, okay, I've ticked all the right boxes. This particular person is suitable for CBT, which we will talk in a minute as to how to identify these patients. But for a CBT model to work, there's something called the brief CBT, and there's something called a CBT in general. So when I say brief CBT, it's trying to combine and condense all the information you have through your assessments. You filter your patient, but more importantly, there are time constraints. So basically, it's me saying that I have a problem, but sorry, I don't have the time to sort it out in long. So when you say this, a normal CBT session, we would suggest between 18 to 24 sessions, which is quite exhaustive. If you try and, even if you take one session a week, you're almost talking of a span of 3 months. But this is where you look at the core elements, and you're as good as going at the grassroots level and trying to work through very slowly to eventually find a solution for these people through CBT. And at the other spectrum is what we call CBT. So basically, brief CBT, sorry. That's basically time constraints, resource constraints, or for that matter, even the patient participation is quite limited. So you condense those sessions. You're basically reducing into half, and this is where we get between 4 and 8 sessions at maximum you have to try and target this particular person's problem. So depending on what particular patient perception portrays a particular emotion, you can initially decide whether a brief CBT approach will work for this person, or this person needs more detailed analysis of complete 16 to 20, 24 session sort of thing. Now, often what you realize is when you initially screen your patients, like we do a detailed assessment for our normal clinical scenarios for MSK, neuro, sports, XYZ, a CBT also involves a detailed assessment. But there are certain elements which are slightly more different, but obvious, because you're dealing with another specialty in terms of treatment options. So you try and explore what we call a bit of educational history as well, as to what is this person's level of cognition, more importantly. But then what you're doing is you're going slightly backwards in digging what we call the past medical history, which we do for other cases. But in that sort of thing, you pick up the medical past medical history, but more important, you try and pick up the past psychological history. And there could be a diagnosis of depression hanging around for years. So that's a major thing to remember. It could be a contributing factor. Also, psychiatric history, equally important. Are there any mental disorders in specific? So people with schizophrenia, manic disorders, they will also come up with complaints of pain to you. And if you're not broad-minded in thinking of, hold on, there is more of a psychological and psychiatric component, as physios, we might try and restrict ourselves to say, okay, the range of motion is possibly contributing to this because of stiffness or XYZ. Yes, that could be a factor, but eventually it's over the years because of this psychological mental history that has resulted in this problem in the action domain. So the main culprit here is the cognitive domain and not the physical component domain. So if you keep handling the physical domain, you're lost out. You'll get frustrated and there won't be an outcome. So you then want to focus on what we call the cognitive domain. And hence, I use the term that CBT is a skill set and it is a structured approach. So it is very important to have a structure. If there is no structure, you will lose out. But more importantly, of course, as a CBT therapist, you will be trained, and you are trained enough to have the structured approach. But the structured approach is not important for you. You will know that because you're a therapist, but it's more important for the patient. Because number one, these patients are usually who have, like I said previously, been through the doors of various specialities. And in a way, I wouldn't be wrong to say that they eventually do not believe in anything. So they say that, there is no solution for this. For example, chronic low back pain. All I'm doing is I'm managing my symptoms through pain relief medications. And, I take those medications, I get ready for a few hours, and then I'm back to, that particular pain zone. So eventually they not only lose trust, fair enough, that's the nature of the problem. But if they do agree to come down for a CBT session, they're looking for a structured approach and they're looking for something different. So to try and restrict them to a particular element of thought process is not going to work. So in a way, it's as good as me saying to you that you say you are in pain, you take an XYZ, and I'm more of an active listener, and I'm agreeing with you for almost everything at that initial session, because you want to try and understand, because an active listener in CBT will pick up specific emotional components. And that is what we need to play around with, that okay, this is what it makes him feel. So this is where the turning points are, as opposed to uh, doing our pain scale and stuff, which is fine, which is important to know where the patient's pain levels are: 0 out of 10, 5, 10, extreme, XYZ, and other contributing factors, and what you've been taking as medication, what you've done in the past. But now what this person is looking for is someone to open up, someone to speak about. Unfortunately, for various reasons, not just in the Asian populations or in the Asian sectors, but even in Western cultures now, from a health perspective, time constraints make it very difficult for a clinician to sit down and actually talk and speak. So most of the times it is a slot which is for 40 minutes, for example. You go in, bang bang bang, offer your treatment, and that's it, you're off. So the patient is sometimes looking for answers which are not necessarily given through medications, through hands-on approach, through modalities, but just by sitting and talking, because they feel there is a component which is not being addressed. So they want to feel part of the journey of the CBT, rather than you being the dominating factor and leading the therapist. Yes, that's equally important, but that has to be done in a subtle way, because part of CBT therapy sessions, which unfortunately we won't be able to go in detail into this session, is dependent on a lot of what we call homework strategy, because you identify a particular perception, you identify a particular emotion, and you work around it, and you give a lot of homework to those patients, and that involves a bit of reading, but at the same time activities, making diaries and stuff. So if that person is not in that particular mind, then you won't expect any significant improvement for that. So this is basically just the first bit of what CBT is all about, and a gist of how we can filter out patients. Now I'm going to go a bit more in detail of how we filter out patients, because like I said, not everyone is suitable for that. Now these are quite self-explanatory, but important just to make a note of it before you screen out CBT patients. So number one, to identify the levels of motivation for these people. So you will have two kinds of patients. Number one, who will in their initial assessment speak out and say that doctor, I'm looking for answers for this. I really need to find a solution to this. This is affecting my personal life, my social life, my professional life. So there you go. You know that this person will listen to you. He will come for therapy sessions. He is motivated, looking for answers. Now the second category, you split it into two. So they will be because someone has referred them, they've come to you. But the initial assessment and the straightforward tell you that I don't think there's anything that can help me. I've seen all possible specialities, the most important people in this area, in profession, highly qualified specialists. Nothing has helped. Now, when they stop at that, saying nothing has helped, you know that the chances are 50-50. They will either listen to you and are happy to take another chance, or they will say, I don't think this is going to work out. So it's worth then not exploring too much of these, because these will be chronic patients. Now, nevertheless, if someone has come to your clinic or someone has approached you just on the initial assessment, you cannot say based on this judgment that he says nothing is going to help. So even you say, sorry, even I can help you. No. But this is important for you to note in the background that the very important factor for CBT is motivation level. And in the background that, okay, this person is category 1, he's motivated, or he's category 2 in that 50-50 domain. But of course, you do not say anything to the patient that, because you're not motivated, sorry, we cannot have CBT. That's not the way to approach. Then second important thing here is time constraint. So again, a very simple and obvious this thing, you will immediately know that the person is willing to engage in time, or the other person is I don't have the time to, come to the clinic every day or XYZ sessions. There, you have 50-50 chances that even if he comes, he might just engage in that 40 minute of session. And after that, the homework that I give him will not work out. So you would then have to tailor your program according that, he's someone who needs to be, given intense CBT in that 40-minute session. Otherwise, going home, it's not going to work out. So time constraint is another important thing you want to note in the background. And this is what makes the initial screening of patient different to our normal screening that we do for other cases that, you're looking for detailed medical, social history, physical function, XYZ. But these factors, they play a very important role, and you're not asking them directly, but by your initial, interaction with the patient, you straight away figure out. Now, another important factor that you need to consider for CBT is life stressors. So the patient will be referred to you for, say, for example, pain. We're dealing in pain in particular for this particular session. So the patient has been referred through various resources or referrals as pain, but you want to identify if there is a life stressor which is giving that pain, as opposed to a particular clinical condition. So yes, if I talk of ortho injuries, pain because of trauma, or neuro injuries, functional disorders, which I will talk in detail, which is an important aspect of CBT, or multiple sclerosis, fibromyalgia. So yes, pain is the main limiting factor. But hold on, is there a life stressor which is contributing to that? And that will open up a different book of problems for us. But nevertheless, that will be the solution rather than working on pain from fibromyalgia or MS or XYZ. So life stressors is important to find out. And this is a very subtle and a very sensitive question to ask. You do not want to ask about that in the very first initial assessment session, because obvious reasons. I'm meeting you for the first time. I don't know you, and you're just asking me if there's something going on in my life at a personal level. That's it. Full stop. I will not come for the next session. So you want to build up that relation, and then gradually in the second or third session is where you will start talking about life stressors in general first, and then open up. The beauty of CBT here is with initial assessment and the first couple of sessions, once the rapport is established, they will almost find you as a friend and a colleague who's been with you for years, and they will just open up things because they find it useful and helpful, both from a rehab perspective, but also from a life perspective, that there's someone who's listening to them, and they're feeling much more happier. Even if that happiness or stress goes away for a few hours, they feel rewarded. That I was in pain for XYZ for so many years, for so many hours a day, but going out there, speaking to these guys, it helps me a lot. They will gradually just open up. So life stressors very important for screening of patients. The next two, I've already discussed that point before, but as a tick list, you want to identify the cognitive levels and the education levels. So that will help you plan your future sessions. And the last one, very important, again, what we discussed in the past, the impact of mental health. And when I say the impact of mental health, I mean, is there a particular diagnosis of psychological or psychiatric pathway in the history or in the background? And if there are elements of important mental health aspects identified in your initial screening, say for example, people will often say that I would rather die rather than stay because of the pain. So people with chronic low back pain sometimes are like, I wish I could die. I cannot. I'm not able to do anything. I rather die. Then amputees. So the phantom pain initially, of course, but then later on in life as well, constant elements of pain and discomfort because of recurrent infections. So they need to kind of come for regular, infection control measures. So eventually they're fed up. Now, to try and identify this suicidal element in the first session is important. And how do you do it? Again, like I said, if I'm seeing you for the first time and you straight away ask me, is this making you feel like you're going to end your life? Even if I don't have the thoughts, in a way, you're giving me an option. So, I don't feel confident in you, and I'm thinking, hold on, I've come to see a therapist, and instead of they offering me some solution, they're asking me whether, I will end up doing suicide. So that perception for the therapist goes in the wrong way, thinking that I don't think this is the right therapist, not experienced, or for a major sake, they might even end up with that conclusion that it's not going to work. But you want to try and identify this through your initial assessment, and don't hesitate if you feel that there is a major element of suicidal tendency in this patient. So there's a bit of this will come with experience and practice, but these patients will not interact much. For whatever questions you ask during your screening, the answer will always either be yes or no, yes or no. They will not open up. Of course, there will be no eye contact, but then also they will be quite sort of fidgety and distracted and just want to finish it off. Or the other sign, maybe they might be quite aggressive. They might be quite sort of absolutely numb, not answering at all. So the impression here is, yes, there is severe depression in these guys. And if there is severe depression, then you need to put a hold on your input at this point of time. We are not the experts here. We cannot do everything. Don't hesitate, refer them to a psychiatrist. Now, this can be quite sensitive and quite judgmental, but nevertheless, it is important. Sometimes you need to do things which people don't like, but it is for their own good. Because here the important element is end of life. They're looking at something which doesn't give them hope. They feel worthless. So this is not our domain. Let the psychiatrists and the psychologists deal with it, and then hopefully once they are out of that end of life zone, they can always come back to us for CBT sessions. But important for us to filter out and then say, okay, I think he needs more help, more specific help, and I cannot do that. Let them see a psychiatrist or a psychologist. Okay, so this is screening of patients. Now I'm trying to figure out if I can. Where are we time wise? We got around 20 minutes more. Is that right? If you look at an hour's this thing. Yeah. Okay. So let me try and speak about something called as building skill sets from a cognitive behavior therapy perspective. Where is this? Yeah. Okay. So there is this concept called as thought records in CBT. At a basic and a layman level, if you break down to two words, you're basically recording your thoughts. But there involves what we call a detailed psychological analysis of this as to what a particular thought is creating in terms of emotions, in terms of behavior, and then what is that person trying to figure out as to how can he get help. So that's what the whole idea is. So what you do as part of CBT sessions is, number one, you do your initial assessment. Now the initial assessment is broken down into two components. Okay, the first is what we do like a normal medical history. So you find out what the background is. Why is the patient referred to you following a trauma, following a neurological insult, brain injury, XYZ, chronic low back pain. So that is more the normal medical bits that we do. The second half of the initial assessment is what I discussed, psychological screening in detail. So exploring more of the mental health element, you're exploring more of the psychological element, and you're exploring more of the cognitive element. So you get a more of a comparison between the two in the initial assessment. And once you've done that initial assessment, your screening of patients is happening simultaneously at the same time. So the points that I just mentioned about motivation, time constraints, previous history and notions, and more important, that suicidal tendencies and stuff, they do not need to be asked in the first session, but you will just pick it up as you're doing your initial screening and assessment. So you have what we call a circle of thoughts through your initial assessment, and then you have a broader picture that, okay, this is where the patient lies at this particular point of time. And then depending on that, you choose out whether this needs a detailed analysis. So is this something that needs to be done over a couple of months, 18 to 20 sessions, or a brief CBT? So that's part one done. You assessed, you screened, and you made a rough decision as to the number of sessions you want. Now you move on to the second bit as to how do you start CBT with these guys, and this is where the thought record system, major theory is based on that, uh, which unfortunately is beyond the remit of this session. But basically, what you're now starting to do is you identify the particular emotion that leads to a particular behavior, and then you start working on the thought process. So, if, for example, I talk about let's simplify this using an example of chronic low back pain. So, through your screening, you identify the patient has come through from an orthopedic or a spinal surgeon. He could have had a back surgery for his back problems. After that, he's also been to a physio for manual therapy, been to other specialties, osteopaths, acupuncture. He's on all possible pain relief medications, high doses of morphine, opiates, XYZ, but the pain element is still there. Okay, so this particular pain is now portraying an emotion in this person, and he's come up with a perception that nothing is going to help, or yes, I'm open to avenues. So this opens up your treatment pathway, that okay, there's a way to work to it. So in a way, this then becomes more of a friendly session to find out as to okay, what is the one thing which is making you worry. So sometimes, like I said, not necessarily it is a pain which is bothering them, because these are chronic patients. So in a way, they are experienced and they know how to deal with it, because they are on the right medication, they have the right support, but unfortunately it is just in their mind now, which is not going. And there could be a genuine element to it. The surgery could have gone wrong, the therapy could not have been adequate. Nevertheless, for us, it is important to know that pain is still there, end of story. And that's the reason he's come to you. So what you then do is, like I said, identify triggers for that. So is there a particular situation, environment that creates that particular pain pathway? If the answer is yes, you explore that pathway in detail and then start working around it. So for every perception that is portrayed out, you want to try and give them an alternative. Now, this is where the challenging part is. You give them an alternative. Say, for example, the patient says, my job profile is such that I need to stand for 5 hours, and just after 2 hours of standing, I get pain. I cannot, continue any further. So the obvious answer to this is you need to take more breaks. You say, okay, so break it down. You don't need to stand for 3 hours. Even if the pain starts in 2 hours, you take a frequent break. Now, the luxury of having a break at all workplaces is not possible, and that option is already explored. So anyway, I'm saying I've tried it. It doesn't work. I still have pain. So now what you figured out here is that there's a negative thought process to a particular alternative. Okay, so these people then go into another category, and we want to find not an alternative, but to work with the negative thought process. Because for them, every solution you give is going to be a negative impact. And we might say, okay, let's change the medication dose, let's make it a bit more stronger, increase the dose and increase the frequency. I've done that. मैंने वो कर चुका हूँ. It doesn't make a difference. Or the other answer is, it doesn't work, or I get more drowsy, so I cannot work. So in a nutshell, for every perception, there is now this negative thought process which is lingering in their head. So the alternative that you give is not going to work in their favor. So what do you do now? So this is where the challenge starts. That I'm here to offer him something, but there's nothing happening. So this is where you start working on what I call the thought record matrix. So you eventually want to break that down into so simplified form that, like I said, for example, he said that pain starts in 2 hours, and despite me taking a break, I cannot work for that. So in a way, now you're completely changing the entire therapy and the treatment strategy, and saying that, okay, you're taking medications at 8 a.m. to go to work at 9 a.m. We will take the medications at 9 a.m. straight away. Now, for a reason, I know that the medications will take time to kick in. So you know that if I change this timing from 8 to 9, he's still going to be in that zone wherein he will be traveling in that zone with pain. So how are you going to help him? But what you're doing here is you're breaking down those thought processes into smaller bits, and you're now trying to say that, okay, what is more important? You picked up in the initial meeting and the thought process that for him work is more important. Okay, so you want to then work around the work element rather than the negative elements. If for him he said that it's a younger generation and sports, or for that matter studies, so it's a 24-hour day. Okay, you cannot expect these patients, chronic pain patients, to be pain free 24 hours. There's no question about it. Okay, so you want to figure out what is the most important part of the day for them and narrow it down there. So this will make them feel that, okay, yes, for me, going to work is more important because I will lose my job. And for those 5 hours, I want to make sure that I'm pain free or minimal pain. So you start giving them options in that 5 hours. You're taking care of that 5 hours. They're feeling good. Their job is done, whatever that may be, work, study, sports. For the rest of it, they now build up a motivation because they see this as a reward that, I was pain free for 5 hours. That made me feel good. I could do my work. And they're now looking forward to it the next day because they know that it helped for them to stay pain free for 5 hours. It will continue every day. So eventually, with that positive mindset, they're also having a good sleep. They're also having a positive attitude towards the next day. They're looking forward to it as opposed to avoiding it. Okay. So these two factors need to be dealt with: avoidance and negative thought process. If you tackle these two, they have hope to start looking at the broader picture. And then eventually there is no denial in the fact that pain has a major psychological and a somatosensory component. So apart from the physical elements of pain and the pain receptors which are important, what is important in pain management and getting rid of or minimizing pain is what we also call the dopamine rewarding system. So for everything that we do in life, we look for a reward. Now, when I say reward, not necessarily material or financial, but at the end of the day, you have a goal towards it. So when you don't get that reward limbic system activated, we wouldn't survive. Now, having said that, at the same time, for a normal individual, the limbic lobe in terms of the reward function is quite active because there are no other distracting factors in their life. There are no life stressors. There could be, but they are minimum. More importantly, we're talking of pain here, so there is no pain per se as such, physical pain. So for them, the reward system is always high. They're always activated. They're always motivated to go ahead and ahead and ahead. But for people with chronic pain, unfortunately, the surrounding distractions are significantly higher. Pain is a limiting factor. So they want to excel, they want to do better work-wise, education-wise, sports-wise, but that is the limiting factor. So pain is a limiting factor for them. So for them, that motivational limbic system is not fired up 100%. So that's the reason you want to make sure that negative and avoidance systems are tackled at the same time. Once they are tackled, they will gradually open up doors for CBT. Now, I know this is a very broad sort of concept that I've opened up. Unfortunately, without going into details of step-by-step analysis, it's very difficult to portray this in this 1 hour session sort of thing. But this is how these sessions will be based. Our normal setting up goals, but more importantly, you're now working on thought aversion. Basically, take up the negative thoughts, take up the distracting factors, take up the avoidance, and gradually things start falling in place. Now, I think you can speak another 5 minutes on specific neurological conditions for this. Me being a neurophysio, I wouldn't miss out on this topic on CBT and neuro conditions. Now, from a neurological perspective, Of course, the list is exhausting in terms of what contributes towards pain. So we could be looking at spinal cord injuries, brain injuries, and cerebral insults in terms of strokes, degenerative condition, multiple sclerosis. But an important clinical condition that sort of falls in this remit is functional disorders, neurologically functional disorders. So, for people who are not much aware of this, of what a functional disorder is, in a nutshell, basically it basically relates to there is no physical element of it. Okay, so physically the person is 100% fit. When I say fit, there is no medical or clinically associated relationship to that particular picture of pain or discomfort. Okay. Second, going at a higher step, there is no scientifically proven uh, prognosis towards it. And when I say prognosis towards it, what I mean is, all the possible investigations have been done, starting from normal CT scans, MRIs to, highly specialized PET MRIs and, CTs, 3D images. Nothing is identified on that as well. So I said there's no proven scientific prognosis for this. So that leaves out what's the problem. Physically, there is no problem. I've done the assessment with you. Everything is fit and fine. Medically, there's nothing. All your physiological components in terms of blood tests, physiological tests, they're all normal. Investigation wise, everything is fine. So these people have what we call a structured negative aversion towards the problem. So it's just in their mind. So functional disorders, they play a very, very, very disturbing role in the society from a neurological rehab perspective, because what do? You not identified a particular clinical condition, you not identified a clinical problem. How do you treat it? So this is where you want to start addressing the CBT element in these category of patients, because unfortunately, functional disorders, they result from this is based on evidence and some scientific literature, from two major components. Number one, a very significant past childhood abusive or depriving history. So these are patients and client groups who, in their young adulthood or slightly higher, age groups, will portray what we call an attention-seeking behavior because of the past medical history of delusions and unfortunately not being taken care of. And secondly is following a major trauma event. So the impact of the trauma from a psychological point of view has been so severe that they do not see anything else beyond this. So they've basically given up in life from a mobility perspective, from a transformation perspective. So these people are now more in that functional domain. The second category, like I mentioned, trauma, they could have undergone rehab, and the rehab reports now show that yes, the goals have been made. There's no further input required from a physical or any other perspective. So these people linger around on what we call functional disorders that way. So CBT plays a major role in this, and you want to try and get back to it. And this is where physios play a major role as well. I'm aware of the time. Very quickly, for functional disorders, when you go to an extreme case, these are people who sit in a wheelchair, but they do not have a spinal cord injury, nor a back injury, nor other any associated joint or degenerative problems, but they've chosen the route to be in a wheelchair. And the one point that they convey is, I cannot walk. So that's it, full stop. So this is where we start working on what we call gait training as well, because eventually we want to get them walking. But the first impact has to be through CBT. You want to find out what is the reason for it. They will explore it. You work on the cognitive element. Once the cognitive element is worked on, action will automatically follow. So there are in fact, there are specific physios here who deal with functional disorders only. They do a good blend of CBT and functional disorders. Right? I think enough of talking and lecturing from my end. Like I said, it's a very nice topic, and it's one of those topics where as physios, you will either like it or you won't like it. to like it, you need to have that psychological sort of this thing in your background. Someone who reads books and someone who's more assertive towards patients, more active listener, as opposed to someone. I mean, for a sports physio, they are running around and highly energetic, active, and to that extent, even orthos, you're looking at getting that fracture rehab, high injuries back to. So you will either like it or you will not like it. But the important key message here is it's a good sort of armor in your background, to be honest, and it will eventually, if you might not use it at the core the therapy concept being a physiotherapist, but there are bits and pieces which you can always use and pick it up. I hope this was helpful to some extent.
Yes, sir, definitely. So I have two questions, if you don't mind answering them. One of that is, how do you know if the patient is actually the pain is because of psychological condition, or if the treatment is not working? Your given treatment is not working.
So there are two elements to this question, Soumya. Majority of these clients will be chronic uh, patients, okay? Because from an obvious clinical management perspective, people with acute pain are usually dealt through what we call pain medications, or through first point contact as physios with us, or a combination of the two, or their active phase is still being explored from a surgical point of view as well. I'm going a bit more in at the extreme ends. So most of these patients will be at the chronic end. Now, once you are at the chronic end, there could be two elements. Number one, they've explored all possible options. Okay, so this is where you know that the pain is coming more from a psychological, because it's now built up what we call that negative and avoidance feeling, which is giving that behavior. Or the second thing is, for whatever reasons, unfortunately, they've not been exposed or explored more of these resources. So they've not enough pain relief medication. They've not seen a good physio. They've not seen other alternatives. So this is where you are 50-50. You know that there is an element of physical aspect of pain management which has not been dealt with. But because this has become chronic, the psychological impact will always be there. Now, to what extent it is there, you need to do a detailed analysis. So this is where you need to go into details of CBT.
So one more question.
Sure.
When we are doing the CBT session, is it generally incorporated with the treatment, physiotherapy treatment that we give, or is it held separately?
I think it's a tricky bit to answer, because what you want to identify is what is your goal in that session. Uh, you know, if I take it, we're seeing patients here for maximum of 40 minutes. So to try and break it down 40 minutes into 20 minutes of physical activity and then physical 20 minutes of talking, you're basically doing a half job for both of them. So I wouldn't recommend that. But it's the other way around, that as physios, and this is what I used to do and I still do, is if the element of pain is 50%, as in 50% psychological and 50% this thing, I do an alternative session. So I have an intense physical therapy session. The next one is talking about it. So you break it down. But then eventually, when you come towards the end, wherein the goals are gradually getting more and more clearer, you can it's what we call the walk and talk session sort of thing, because you now reached a point wherein you're doing more of community rehab in terms of gait training and stuff. So with your gait training in the community, walking outdoors, you can also do your CBT in the background. But it's a difficult question to answer, to get a precise answer. You will get this more from experience.
So one last question.
Sure.
You said that we generally don't ask for light stressors in the first session itself, because of course we don't want to scare the patient away. So do you advise asking them before the pain goes towards the chronic condition, say in the second or the third session itself, when you're building a rapport with them, or we should ask them once the psychological aspect is coming into picture?
Okay. I think the trick here is that although I say you don't want to get too personal and ask sensitive questions in the first initial, no one will like it. But if you're lucky enough, the patient might just open up straight away. So that you've been lucky and you got your life stressor as a major contributing factor. But if not, then I usually recommend that it's trying to establish a rapport, and what will happen is in the third or fourth session is where, if the patient doesn't open up, you now have the opportunity. But at the same time, it is important for you also to ask that question. And the fact that the patient has come for 4 sessions means that he's engaging, he has positive thoughts coming into it, and you start a gradual thing that sometimes we ask ourselves that I've tried all possible things. There's something which is missing here. So you put it in a friendly way and say that is there anything else happening in your life which could be affecting this, and they open up, and that's where you then start dealing more in detail.
Okay, I think my questions are answered.
Okay.
So we'll end the session. On behalf of Physio TV, I would like to take this opportunity to thank you, sir, Dr. Hamza Godhrawala, sir, for enlightening us with this commendable talk and for clearing our concepts and enhancing our understanding pertaining towards this domain. Of course, it's new to us as well. Looking forward to collaborating with you, sir, again. I would also like to thank Dr. Sona Konke, ma'am, our Associate Professor and Head of the Department of Kinesiotherapy, Apurva Shimpi, sir, our Principal, our Chairman, Dr. Parag Sanjeti, sir, our Executive Director, Mrs. Manisha Sangvi, ma'am, our technical team, and of course, our dear viewers of Physio TV. Thank you all and have a great day.
Thank you. Thank you very much.